I'll go to start. I think we can start. No more people will come for sure. So I welcome everybody of you in the late afternoon, and thanks that you are here to support us, that we are not just alone with Professor Tachkina. So I would like to introduce myself shortly. I'm Jana Alešová from Czech Republic. I'm president of Czech Society of Pediatric and Adolescent Gynecology, and I would like to welcome my colleague from Ukraine. You know her for sure. Just shortly, she is Dr. Professor Irina Alextochkina. So, I would like to introduce you Daniela Dingelding from Swiss. She was introduced for several times yet. So I would like to ask you to present your work. Thank you.
Thank you. My name is also Irina. So I'm here for my friend. She couldn't be here today, so I will present her work. Do adolescents show different symptoms for endometriosis than older women? And now there is no pointer. She has no disclosures. The aim was to compare the symptoms of adolescent patients with those of adult patients clinically diagnosed with endometriosis. The background is the symptoms of endometriosis already occur in adolescence. 2/3 of women diagnosed with endometriosis in adulthood had symptoms before the age of 20 years. I also have to say, like this morning, if I say women, I mean all beings, individuals with menstruation, which menstruate. We have to begin to be correct with our language. I'm not that used to it now. The diagnosis of endometriosis is delayed, on average 12 years. And adolescents wait 3 times longer before seeing a doctor, around 6 years. Adolescents need to see 4 to 5 different doctors before the diagnosis is established. The main symptoms are non-cyclic chronic pelvic pain and dysmenorrhea. However, little is known about pain intensity and different types of symptoms. To improve early diagnosis, a deeper understanding of the symptoms of young patients with endometriosis is required. Between 2017 and 2020, all patients at University Hospital in Bern with the clinical diagnosis of endometriosis were included. Patients reported visual analog scale scores for non-cyclic pelvic pain, dysmenorrhea, dyschezia, dysuria, and dyspareunia. Data were analyzed and compared between the adolescent patients and the adult patients. The adolescents with endometriosis were analyzed in greater detail, comparing visual analog scale scores and types of endometriosis. From 826 patients, 144 patients were younger than 25 years. 92% of these adolescents introduced themselves because of pain. Young patients had significantly higher pain scores for dysmenorrhea, dyspareunia, and non-cyclic pelvic pain compared with the older patient collective. Visual analog scale scores for dyspareunia were reported significantly higher even with an earlier stage of endometriosis. Here you see these results that I told you on this scale. The young collective had higher values of dyspareunia and higher values in dysmenorrhea than older patients. The conclusion is an early clinical diagnosis and empirical treatment to reduce the pain and to improve the quality of life of these young girls is absolutely needed. Dyspareunia in adolescents in particular remains greatly under-investigated and merits more clinical attention. Comparing the symptoms of adolescents and adults in our study demonstrate the degree of suffering even at young age. Thank you for your attention.
Thank you, Irene, for your short presentation. So everybody is glad this was short, but very interesting. Of course, I think the main problem is to diagnose whether as organic or psychosomatic problems. That is the line. Is among all our patients, whether as two or not, where is the true response to the problems. Okay, thank you a lot. So, any questions? Okay. Then, Irene, don't leave us. There is a question.
I'm sorry.
I wondered if you'd be doing any further study to look at the effectiveness of treatment strategies, because if symptoms for those with pelvic pain is more pronounced in adolescent years, I wondered if treatments would be less effective than in adult years. Just a thought, really.
Yes, it is in plan to make a follow-up of the treatments. And the most patients in Switzerland, the adolescent patients, they have a Visan. I don't know if you have the same name here. It's the medicament progesterone to treat this. And as we heard this morning from Mark Lofer, we try to do one good operation. This is the aim that we have also.
That'll be very valuable data. Thank you.
Okay. Next question.
Thank you for so good presentation about a huge population of adolescents with endometriosis. I have a question. What is your opinion about stage 4 diagnosis of endometriosis for adolescents? What should we do? Firstly, secondly, and before operation, say this is endometriosis.
We do, as we heard also this morning, the algorithm that Mark Lofer he showed this morning, we do like that. First, we try with the combined oral contraception pill for 3 months. If it's okay, then we say it's a primary dysmenorrhea, and then we change the options to other methods like long-acting contraception or the Visan. And if it doesn't work out, then finally, it is the laparoscopic diagnosis to take if there is. But very often, it's enough. Like that, we do it.
Thank you.
That means surgery is the third step, yes?
Yes, surgery is the last step. Sometimes it's the possibility to make an MRI also to look if you can find very, very little lesions, that there is some possibility with MRI now, the new techniques, to find really little lesions to know that is endometriosis. But if the hormonal therapy is enough, so we don't need operation so far.
Okay. Thank you a lot. Thank you. So I would like to invite Sarah Channing from the University Hospitals Bristol to present.
Lovely, thank you. So I'm Sarah Channing. Thank you for that. I'm working in Bristol and I'm a post-CCT clinical fellow. So having spoken to a couple of people, I've now realised that doesn't mean a great deal to people, but it kind of means I've finished my PAG training and I'm waiting to be a consultant. This sort of short presentation is just looking at an outpatient service evaluation that we did, looking at sort of our tertiary referral centre in Bristol to see what we have coming through our department. This work was done with two of my junior colleagues, Sophie Kenyon and Chloe D'Souza, under supervision of Naomi Crouch. No conflicts to declare.
Okay, stop.
Oh, I can see it on here, but you guys can't see it. Ah, it's not on the big screen.
Okay.
Excellent. Sorry, so there we go. Just a little bit of background as to who we are and where we come from. So Bristol is a city in the southwest of England, so you can see on the map there. And I've also realised I should probably say that in the UK, patients have access to free healthcare through the NHS, through sort of the tax system. So all our patients that come to us don't have to pay for their care. They are all just coming as from a referral, usually from a primary care physician or from another colleague that's working somewhere else in secondary care. We are a tertiary referral centre for PAG, and we do take patients from all of the southwest of England and some from South Wales as well. At the time of doing this project, we had two PAG consultants, so Naomi Crouch and Bryony Strachan. And in our service, we have general PAG clinics. We have a monthly adult endocrine gynecology joint clinic, which is normally kind of our Turner's clinic, is the most common thing we see in there. We have a monthly satellite clinic at Gloucester, which is about 40 miles north of Bristol. We're an NHS England commissioned service for complex congenital gynae. We have an MDT specifically for our DSD transition patients who are so our younger patients transitioning through to adult care from paediatric care. And then we have a separate sort of more general PAG MDT. And for those patients, as I say, we have that are transitioning into adult care from paediatric care, we have a quarterly clinic. The reason that we wanted to do the service evaluation is that we were getting quite a lot of pressure for outpatients, which I think is probably quite common in lots of places from talking to people. And we sort of have a target of a less than 12-week wait for people to come into clinic from primary care, and we were averaging about 21 weeks. So we wanted to have a look at our services and work out who are we seeing, and is there anything we can do to try and streamline things. So we looked at a period of a year of appointments just pre the UK COVID-19 restrictions, because we didn't want to kind of actually have the influence of that, because we basically ended up doing a lot of telephone appointments during a lot of that time, and a lot of our outpatients were adapted quite significantly. So this is all data just prior to COVID. And we went through every set of notes, which was all electronic, just to mainly look and see what the main reason for attendance was. And the main reason for this is we wanted it to sort of inform any future service developments that we were planning and sort of facilitate sort of data-driven streamlining of our outpatient services. So just to give you an idea of numbers, this is quite different to the last, when we were in the last session. We had in China, but they had sort of 31,000 coming through there. So we have 385 appointments in our PAG service over a year. We had data for most of those, and most of those patients were PAG patients. Some were general gynecology patients in those clinics, but of those 338 patients, we had a 5% DNA rate, which is underneath, sort of below the average for the UK, which is sort of people not turning up to their appointments. But as I say, people aren't paying for them, so we do have it's somewhere between sort of 5 and 10%, I think, in the UK on average, so not too bad. We looked at, as I say, mainly what was the conditions that we were seeing. So you can see we've got quite a wide spread, and they're all things that we'd expect to be seeing in a PAG general outpatients clinic, but there was clearly quite a trend that there were a few that were more common for us to be seen, and I'm going to focus a little bit more on those. Our average age that we were seeing patients at was 16. Our three sort of largest cohorts I'm going to focus on, so our Turner syndrome patients come to our joint adult endocrinology clinic, which we hold monthly. And at the time of doing the project, we had one clinic a month where we would see sort of 6 patients. And we had a few extras to take us up to 54 appointments over the year. But we'd had 8 new referrals into that service that year. And actually all of those patients were having at minimum an annual review to look at all of their sort of health checks from heart, bone, ears, renal, autoimmune, and checking on their HRT requirements. So it's an increasing cohort if we're having somewhere around 8 new patients coming into every year, so that's going to be a sort of increasing cohort, and they are complex patients requiring specialist care in that joint clinic, and we didn't want to put them into our general PAG clinics, so that was an area we definitely needed to think about how we could increase capacity in that area. And then our sort of next biggest group was the heavy menstrual bleeding group, and I think this is probably common to a lot of services, that it's the most common reason that we have for people being referred in, and we had 24 patients over the year, and most of these patients did require a follow-up within that year as well, so it made up quite a lot of our clinic slots, and I'll talk about how we sort of have thought of a new novel way of managing those. And then another sort of group that we've put together, our POI and late effects patients, makes up around 50 appointments over the year. And these were scattered in amongst all our general PAG clinics. And again, about 6 new referrals into this. And some of those do require long-term follow-up. So they're another group that we haven't yet sort of streamlined, but we are thinking about what we can do with those. So the streamline that we've done, we have recruited a second endocrinologist, which has allowed us to double our capacity in our Turner syndrome clinics. Those patients are now managing to get their follow-up at the 12-month point that they're meant to be having it. We have now a face-to-face stream and also a telephone stream, which means that some patients have a telephone appointment rather than having to come all the way to Bristol to see us if they live a little bit further away. And if they've had a recent face-to-face review, then actually that's an appropriate thing for us to be doing every so often if they're not coming to the time when they need lots of investigations. And if their primary care provider could do their blood tests, for example, that they need. And then our adolescent heavy menstrual bleeding clinic is something that we've got a poster here that's talked about this clinic that we've piloted. And because this was our biggest bulk of our new referrals, we had an idea of running a one-stop monthly clinic for this, which would allow us to kind of actually just streamline their care a little bit. And one thing that we've put into that clinic is that we offer those patients a transabdominal ultrasound, and not with the thought that the majority of them are actually going to find anything that's going to influence the care, but it actually does act as a reassurance for a lot of patients. And a lot of our patients were ending up with an ultrasound at some point in their first kind of year during their journey with us, which was requiring them to obviously come for their first appointment, go and have an ultrasound at another time, and then come back to us for a follow-up. But within this setting, they have their ultrasound as part of their first appointment. And we've made these appointments so that it's an afternoon clinic, and we have all of our face-to-face new referrals at the beginning and then our telephone follow-ups at the end, which means that those are usually after school hours. So those girls are now just missing 1 day of education to come to their clinic appointment with us, or a half day if they manage to just come in the afternoon. So sort of reducing their missed education. And we've piloted that, and that is something that we're going to take forward. As I say, I've got a poster on that here too. And then we have managed to use some of this data to help us to recruit a new consultant, Sarah, who's also with us here today. So that has helped us to boost capacity, but it's through these types of projects where you can sort of see that actually where your gaps are and what you do need to boost to, that you can actually provide some evidence for that. And Sarah is PAG and fertility trained, because she's done sub-spec repro medicine training, which just means actually we can make use of her fertility and reproductive medicine skills within our PAG service. And one of those things that might lead us to be able to do is potentially a primary ovarian insufficiency and late effects of childhood cancer service. We also are very lucky to have a menopause service that's recently started, and if we can potentially combine all those skills, we might be able to have a one-stop clinic for those patients where they can draw on the sort of skills of those different clinicians. And we also have a psychologist who works with us who would be able to provide support. We also probably need to start thinking about using technology a little bit more. So at the moment, our clinic's a little bit mixed up. We have some face-to-face patients, some telephone patients, some video patients, and I think we could probably streamline that a little bit better so that we make use of all of our face-to-face clinic slots with face-to-face patients who need physical review, and then have some clinics that are telephone or video clinics, and they might be able to be done from home, because within the NHS, there's often capacity issues with patients, but there's also often estate issues, and that we don't always have enough rooms for the clinicians that we have to see all the patients. So that's something we need to think about. We need to look at the roles of a specialist nurse, potentially, who might be able to take off some of the burden of some of the appointments from the doctors. They might be able to follow up for patients who are on HRT, and potentially follow up for our patients who are having vaginal dilator therapy. And then I've just got a little map there that just shows where all of our patients were coming from. And as I said, we already have a satellite clinic in Gloucester, which is about 40 miles to the north of Bristol. Gets patients from kind of those postcode areas. And they weren't included in this audit. But actually, as well, we have recently, in the last couple of years, joined with Weston-super-Mare into our Bristol Trust. And there are some areas of quite high deprivation in Weston, and it might be worth us in the future thinking about having a clinic there. so that those patients can actually have access to care closer to home, which might actually help reduce some disparities in sort of their care. And then Taunton is slightly further down towards the south. It's the TA postcode area that you can see on there. And we have a lot of patients that travel quite a long way, and it doesn't look, this is like the bottom of England, bottom southwest corner of England, but actually those patients, it can be a good 2-3 hour journey to come up right from the south. But we're also training colleagues like Kirsty, who's here, who's doing some training with us, so actually it may be that we can set up further services down south as well in the future. So in conclusion, this was a really powerful tool for us as a department. It helped us to identify our heaviest workflows and allowed us to streamline, and has enabled us to provide evidence for expanding our team and kind of changing our services. And I think we should consider doing this sort of type of review every 3 years, and at times of change. So we've just recruited a new consultant, and it might be worth in the next sort of 12 months again thinking about, do we look at this so that we can actually look at our services and see where we are. And it is a really good sort of quality improvement project for any doctors interested in service development. I found it very useful to kind of actually do this project because it has actually opened some doors to work out, actually, I can set up a new clinic through this type of project. Thank you.
Thank you a lot. Thank you. So, have you got any questions? Everything is clear? Okay. Thank you a lot for your presentation. And I would like to invite Mrs. Diana Safitri-Velias from Indonesia, a member of Department of Obagian Faculty of Medicine, Tangerang, from Indonesia. Welcome.
Thank you very much. Good afternoon, everyone. So, as previous colleagues from Malaysia say, she traveled all the way here, 18 hours. I spent 24 hours. So, but it's very lovely to be here, and I'm presenting here on behalf of my student. And please don't get bored with me yet, because I have 2 presentations today. What we are going to discuss for the first one is what are the factors affecting health-seeking behavior on primary dysmenorrhea in our faculty, in our university students. I have nothing to disclose. So dysmenorrhea incidence in Southeast Asia is quite high, around more than 80%. And in Indonesia is the 4th largest population in the world now. And we have 64% of women having dysmenorrhea, where half of them are patients with primary dysmenorrhea. The problem is discussions about menstruations are considered taboo, where 26.6% do not wish to seek help because they think menstrual pain is natural, it is normal, and women have to bear with it. But we all know that neglecting dysmenorrhea will delay diagnosis of endometriosis, like previous speakers already mentioned. So we believe that understanding factors that are affecting health-seeking behaviors can help us to give better interventions. So we wish to determine factors that are affecting health-seeking behaviors. We use a cross-sectional study, and we use a VMSS, Verbal Multidimensional Severity Scale, to assess severity of dysmenorrhea. And then we also use questionnaires to assess the knowledge, attitude, and also behavior of health-seeking of dysmenorrhea. And these questionnaires were validated from previous research in our language. The research was conducted before the pandemic. It was in January to March 2019, and we got ethical clearance from our faculty. So the inclusion criteria is students who are experiencing dysmenorrhea, and the exclusions are those who have gynecological disease like cyst, endometriosis, or adenomyosis, or other gynecological disease, and chronic pelvic pain. So these are the results. The respondents' age are between 17 to 21 years old, and we divided here based on faculty or their major. Most of the respondents are from non-health faculties. The health faculties that we have is only nursing and medicine, so the other respondents are from other faculties. And most of the respondents have a normal menstruation. If you look at the result of the VMSS score, more than 50% of the respondents have mild symptoms, while 40% have moderate to severe symptoms, so it's quite high. And regarding the knowledge about dysmenorrhea, actually based on the questionnaire, it is stated 60% have a good knowledge on dysmenorrhea, while 39% or almost 40% have poor knowledge. How about the behavior? Most of our respondents, like you see here, 39% do not do anything without for their pain, and 38% is doing self-treatment by means like putting heat, some heat pad, or maybe just sleep over it and do some relaxation. And only 20% seeking over-the-counter drugs, and the rest is traditional therapy, such as taking some herbs, or some herbs. We asked about source of information on dysmenorrhea because we believe that this will affect a lot about how their perspective on dysmenorrhea. And most of the patients got information from their family, and then friends, and next is internet. So very little information from healthcare providers. We did a bivariate analysis regarding dysmenorrhea severity level, whether it affects the health-seeking behavior or not, or the knowledge it can affect the health-seeking behavior, and attitude. While the results shows that only attitude shows a significant effect on the behavior, while the other does not. We thought that if patients have moderate to severe or maybe severe pain, they will go for seek for help, but turns out not that way. So pain is an individual feeling. The person does need to have a good knowledge actually to carry out health-seeking behavior. If you feel pain, you just go to find help. But doesn't work that easy regarding this dysmenorrhea. And attitude is an evaluation predisposition that determines the way an individual will act or behave in the future. So the example of good attitude that we discuss is to assume that dysmenorrhea is a disease that must be treated, and every woman deserves to get best treatment. Knowledge and attitudes toward dysmenorrhea are greatly impacted by social determinant factors, by means their family, their friends, school, and society. And respondents in this study, we already have from diverse culture and also religion background. If you know Indonesia, we have very diverse population and also many religions. And we all already cover that, but since this is a private university, we can only cover similar social economic status and education level. And this study does not analyze furthermore about other factors that could affect this health-seeking behavior. So as a conclusion, positive attitudes towards dysmenorrhea will significantly affect health-seeking behavior, while severity level and knowledge did not. And we believe that further qualitative study is needed to explore more about this behavior, and further study is also needed to understand what happens in more diverse samples. Thank you from the beautiful beach of Papua, the eastern part of Indonesia.
Thank you a lot, Diana. And any questions? Yes, please.
Maybe you hear me as well. You mentioned that your questionnaire was used as previously validated from another study. Did you have opportunity to compare your results to the results of the previous study?
Yes, so regarding the knowledge, the attitude, and the practice are actually quite similar. Although their populations are way younger, they have respondents from high school and junior high school. So we have a different respondent, but actually it's quite similar.
Thank you. And sometimes it is quite useful to use such a questionnaire or to make such a research to motivate the persons to, or the people to do something with that. Was this research some motivation for your patient? Do you think so?
Well,
yeah, because if they are content or not content with the pain,
Right.
so there is no doubt they are not content with some complaint. Yeah, but
Right.
perhaps this could be motivation. Was it or not?
Well, we didn't actually think that further because at that time we only analyzed whether they have a good knowledge and attitude about dysmenorrhea or not, but we didn't measure whether later after the study they have a better understanding on dysmenorrhea. But this gives us some opportunity to reflect how we do our sexuality education. So now we are putting more emphasizing about menstruation and discussing more about symptoms related to menstruation, because not only dysmenorrhea that is neglected, but also premenstrual symptoms that is neglected. So not on that population, but that gives us idea for our next project that when we go to community, we emphasize more about menstruation. But thank you.
So it was inspiring for you predominantly.
Yes, I guess.
Nice lecture.
Thank you.
Okay, I think the main problem is that you have to fight against very strong religion lobby that used to say that menstrual is something that it's taboo first, and second it's something dirty. So
Right.
that's why I think that's why the reason that the young girls or women generally are not in a well to speak about their menstrual problems.
But if you hear this morning topic about the application on menstrual period,
Yeah.
about OKI, we are using that in Indonesia, and I'm also helping these applications to help gather more subscribers. And during these periods, we are adding more information about dysmenorrhea. And I'm also entering this religious school called madrasah. This is an Islamic school, and they now beginning to open more about this dysmenorrhea. Although for Muslims, they cannot pray when they have menstruations,
Yeah, of course.
but we can say that this is not dirty. Menstruation is normal. It is not taboo. So it is now becoming more and more a social media campaign.
Okay, no matter this, I think that is a long way in front of us. Thank
Yes,
you a lot.
thank you.
Okay. Next question. Diana, please don't leave us.
Already finished. Sorry.
Okay.
You received very important results. Thank you. But my question is not about your presentation, maybe over. Is it in plan, or maybe it's done, your study about treatment of this dysmenorrhea? Because if treatment is successful, it will be the most important part to involve population for knowledge about dysmenorrhea.
Right, that is a very good idea for our next study. But you know that when I ask patients why you don't seek for treatment or even go to the over-the-counter drugs, it's because they are afraid they will get addicted to these analgesics, while analgesics do not make you do not make addictions. So that is also one thing that we need to help to counter the issue, that we need to make people understand that we need these medications. But yes, we don't have, I don't have any results regarding the treatment, but I would love to see more in our population. Thank you for the
Especially
suggestions.
for severe dysmenorrhea.
Right.
It's not all time need contraceptive pills, you should give some non-inflammatory drugs or some else. Thank you. It's very interesting.
Thank you. And I also need to explain a little that we don't have PAG service in Indonesia, and I'm not yet a PAG, so we're heading there.
But you have a good specialist in your country.
Thank you.
Thank you. Thank you very much.
Thank you very much.
And I would like to ask Professor Tachkina to present her presentation.
Dear Congress Committee, dear colleagues, let me express my sincere gratitude for the invitation to the Congress. Also, best wishes from my Department of Obstetric Gynecology and Pediatric Gynecology. This is a photo of my department. And all pediatric gynecologists of Ukraine. During the years of independence after the collapse of the Soviet Union, differential program for reproductive health have been created in our country. Thus, the Order in Pediatric Gynecology Service of the Ministry of Health was created for improving specialized medical care in pediatric gynecology. In the Kharkiv region, we have created a structure that provides early diagnostics and treatment for PAG. Pediatric gynecologists were trained and specialized medical institutions were created in the PAG system. In addition, a complex multi-level system of obstetric gynecological care of this contingent was established. Such was the situation until February 2022. And the war made it sterile adjustments in our lives. Despite the war, the PAG service in our city has been working and helping our patients. On this slide, you see my colleagues in their workplaces. Since February 2022, active hostilities with daily bombings have continued in the Kharkiv region of Ukraine, bringing great suffering to the civilian population. This has a determinant effect on the psycho-emotional state of children and adolescents. On this slide, you see the aim of our investigation. The research objectives were to specify reproductive system dysfunction and the psycho-emotional state in female adolescents, compare the psycho-emotional response in stress in adolescents and young women, develop practical recommendations for providing emergency gynecological care to adolescents under stress. From March to November 2022, 43 patients turned to our clinic, included 28 adolescents with menstrual dysfunction, is the main group. The survey involved 21 young women, students of our university, who were also in the Kharkiv region in the same time. All patients were consulted by psychologists. For the diagnosis of gynecological pathology, the necessary and sufficient methods in adolescents were used. To determine the level of stress and its influence on menstrual function and the state of the psycho-emotional sphere we used. Results. Most adolescents of the main group were diagnosed with abnormal pubertal uterine bleeding and post-menarche anemia. At the same time, young adults maintained a normal cycle, and only in 19% menses became scanty. Testing revealed that both teenagers and young adults were in a state of chronic stress, increases anxiety, fear for their lives of loved ones. The high stress level of more than 150 points was recorded in 90% of adolescents with abnormal pubertal uterine bleeding, which means a 50% increase in the likelihood of any somatic disease. In adolescents with bleeding, both the highest frequency and the indicator of the level of personal anxiety as the main reaction to stress were revealed. Based on the data obtained, the following recommendations were proposed: hemostasis and subsequent therapy of abnormal uterine bleeding in adolescents in the conditions of the uncertainty associated with hostilities should be as quick, as effective as possible. And the first line of therapy is the use of combined oral contraception pills. Individual or group work with a psychologist in decisive in providing general and psychological assistance to adolescents in conditions of severe acute and chronic stress. And conclusion. Severe psycho-emotional stress can be a trigger for the occurrence of serious menstrual dysfunction during puberty. Adolescents are more vulnerable to stress than adults, and the changes in menstrual function are more profound. They develop abnormal uterine bleeding with post-hemorrhagic anemia or amenorrhea. In conditions of chronic stress, it is necessary to include the help of psychologists in the complex of treatment of adolescents with menstrual irregulations. Thank you for your attention, and we hope for our peace future today. Thank you very much.
Thank you, Irina. And we hope that the situation will be better very, very soon. I think there is no person in Europe or all over the world that wish you the peace and normalization of situation. Thank you.
Thank you very much, and thank you for all this colleague for support. Thank you.
Okay, and Diana, we love you a lot. Come on to us again, please, and present your next presentation. Thank you.
That's why I said do not get bored with me yet. So actually, this is also another study of my student, because they are the one who's supposed to present this, but it's too far to come here. So, sorry. This one is also about dysmenorrhea, but we are comparing between facial pain scale, FPS, verbal rating scale, VRS, visual analog scale, VAS, and numeric rating scale, NRS, on pain intensity during dysmenorrhea. I have nothing to disclose, and we already know this data before. So here are the pain scales that I'm talking about. First is the FAS, only straight line, of 10 millimeters line, and with explanation only no pain, and pain as bad as it could possibly be. And then the second is a numeric rating scale, where each centimeter has number from 0 to 10, and then 0 is no pain, and 10 is worst possible pain. While the face rating facial pain scale has some pictures where they can compare their own face with these faces and say what number is your pain now, 0, 2, 4, 6, 8, 10, and with explanations below. And the last is verbal rating scale, where we rate this pain based on the intensity that patients say, so it's based on patient's statement. We usually use the numeric rating scale, but in this study I want to compare with the other pain scales. From previous studies, there are already people who are comparing VAS and numeric rating scale, and it has a strong correlation. And there are also who compares FAS and NRS in measuring chronic pain, and it's also good. And there's also that measures FBS, VRS, NRS, and VAS in measuring musculoskeletal pain. But in Indonesia especially, we don't have research that are comparing all these tools. And also, most of different studies recommend different instruments to measure pain intensity. And previous study did not take into account the objectivity of pain during dysmenorrhea. So usually they just ask what you experienced when you had dysmenorrhea, but not during menstrual period when they have dysmenorrhea. So the objective of this study is to compare between various pain score instruments for girls with dysmenorrhea. This is another cross-sectional study, and the pain intensity was measured using the VAS, NRS, FBS, and VRS. This research were done during the pandemic, January to April 2021, so we had an online research. We got ethical clearance from our faculty. We include every female university students who are having menstrual period during their menstrual time. So we ask the respondents whether they are in their menstrual period or not. If they are, then we include them. If they're not, then we exclude them. And we also exclude respondents who are using any contraceptive methods. So from 128 participants that we gathered, 12 were excluded due to the exclusion criteria, and only 116 participants included. So most of our respondents have a regular cycle and not using any analgesics, quite similar with the previous study. And we compare between FAS, FBS, VRS with NRS. So FAS with NRS, numeric rating scale, FBS with NRS, and VRS and NRS. And actually, all the scales showing good correlation with the NRS, but FAS has the best number on kappa Cohen's value. So it has an almost perfect agreement with NRS. And all the p-values are significant. The FBS and VRS also has a good agreement with NRS, but not as strong as FAS. This is in accordance with the study before, because FAS and NRS can measure a pain intensity, but not influenced by other confounding factors. And while VRS visual is induced by lower quality of life and daily activities, work, social activities. And also the facial pain score is influenced by emotional factors due to the different facial expressions used to describe pain. So if they think their face is not like that face, so they might choose another scale. And we also measure the sensitivity and specificity of these three tools compared to NRS. And FAST actually has the highest sensitivity and specificity across different pain intensity, whether it's no pain, mild pain, moderate, or severe pain. And FPS and VRS still have a good sensitivity, although not as good as the FAST. So we can conclude that all are actually valid instruments to measure pain intensity during dysmenorrhea. Regarding the positive predictive value, actually FAST has the highest PPV across pain intensities, especially to severe pain. So it can actually show pain as when they have pain. And for the negative predictive value, FAST also has the highest NPV across all pain intensities. So it can also show if the patient says no pain, that they don't have any pain. But we cannot use a scale without asking the respondents whether it is easy or not to use this scale. Because we give this scale one by one, so not all together. And most of the respondents say that the easiest to use is numeric rating scale. Maybe because of the numbers, it is easy to measure. But the most difficult one is FAST, because it's just a straight line and they don't know where to put the line, the dot. So FAST actually has a better ability to discriminate pain intensity, while facial and verbal rating scale can lead to ambiguity. We believe that good validity and accuracy are needed for early screening and identify pain intensity during dysmenorrhea faster leads to more efficient treatment. And accuracy, of course, affects diagnosis. And the accuracy affects treatment. So as a conclusion, the FAST, FPS, and VRS are all valid to measure pain intensity during dysmenorrhea. FAST is actually considered a better instrument, but for patients it's the most difficult to use than the facial pain score or the verbal rating scale. But numeric rating scale is the easiest one. And I think we need a further study to measure whether it is better to use one by one or all of it altogether. Thank you. This is from West Java, Indonesia, where this is my hometown. Thank you very much.
Thank you, Diana, for your presentation. And I was very satisfied when I saw that you offered your respondents the imaginative rate to express their feelings by face emoticons. It's really funny and imaginative, because I think that it's not problem for students to rate the severe of their feelings of dysmenorrhea. But if you want to do a study among normal population, not educated, well-educated girls, so the facial emoticons is the best way, I think.
I think, yeah.
Congratulations.
Thank you very much.
Okay, there is a question.
Okay.
I see you decided to show dysmenorrhea from all sides. Nobody show dysmenorrhea like you. Questions 1. What is the best scale for your opinion?
For my opinion,
Yeah, for your
in my own practice,
your own, yes.
I use all.
Personally, yes.
I personally use all.
All.
Yes, all. I put all four all together in one piece of paper, and I ask them to point which one. And then I ask them to take a picture of it, and then to make a record every time they have dysmenorrhea. So I allow them to measure subjectively their own pain, but I don't want them to stop at that time. I want them to know, to understand whether the pain has increased or decreasing, or it's still like that over the time. So I used it for follow-up.
And next questions. How you decided that dysmenorrhea is severe or mild or not so important problem? How you decided? But by scales or some other symptoms?
Well, this is only a pain, about
Only
pain
pain.
intensity.
Only scale?
This,
Only by scale?
This study is only about pain.
Yes,
but
yes, I know.
during practice,
Yes.
no. We measure everything. Also how it affects their daily life, whether they can function well, go to school or not, and
Yes.
so on.
Yes, I agree with you, because scales is subjective, and you can aggravate or not, or try not show the real pain. And what about the additional symptoms, dysmenorrhea, for example, vomiting, nausea, frequent stool, and so on?
Yeah, I asked that in my practice, but we don't have it in this pain
Yes.
scale. So probably, I'm not saying that this is the best tools to diagnose dysmenorrhea, because it's only focusing on the pain, like you said, but maybe for the other symptoms, we can use the previous, the one from the previous study, the VMSS, because in VMSS, they will say it's severe if it has more symptoms other than just the pain. I think for other symptoms, we can cover by the VMSS, the verbal multidimensional one.
I ask you about additional symptoms because it's a characteristics of primary dysmenorrhea, and we can some differentiation for during the investigation. And very simple treatment can be used for eliminate this problem. So I hope the next Congress will show us all aspects of dysmenorrhea, and we will like to see your investigation in some journal important. So it's very difficult task, because all gynecologists would like to operate, and no one would like to check some symptoms and then and then see what is happened. Thank you very much. It's very important important investigation. Thank you.
Okay, thank you. Thank you very much for your presentation and for your discussion, and thank you all for your patience. Okay, so I think we fulfill our program, and I wish you a pleasant evening and enjoy Belgrade. See you.